Ya estamos en vivo en Facebook.
Estamos en vivo en ambas plataformas.
Ok. Muchas gracias, Sandra. Buenas noches a todos. Es un gusto darles la bienvenida a esta sesión académica correspondiente al mes de abril. Nos acompaña nuestra presidenta, la doctora Mara Medeiros, y es un gusto para mí presentar a alguien que no necesita presentación en realidad, el doctor Dorry Segev. Él es cirujano de trasplantes, es el profesor Pozefsky de cirugía en la Escuela de Medicina Johns Hopkins. También es profesor de epidemiología en la Escuela Bloomberg de Salud Pública del mismo hospital y universidad. Y es el vicedirector del Departamento de Cirugía del Hospital Johns Hopkins. La verdad es que él ha trabajado muchísimo en la aplicación de diferentes modelos matemáticos para poder entender y para poder mejorar la atención que le damos a los pacientes y su acceso al trasplante renal principalmente, y un poco de aportaciones también al trasplante hepático. Nos da muchísimo gusto darle la bienvenida. Él nos va a estar hablando acerca de la utilización de riñones de donantes cadavéricos provenientes de donadores que antes eran conocidos como donadores de criterios extendidos o donadores marginales, y que gracias a sus aportaciones hoy los conocemos como donantes con un puntaje de KDPI alto. Muchísimas gracias, doctor Segev, por aceptar nuestra invitación y por participar en esta sesión.
Great, thank you for the kind introduction. Buenas noches to everyone. I apologize, I will be speaking in English, but fortunately we have a fantastic interpreter to help. I wish we could be doing these things in person, but we still have a bit of a pandemic, although I do hope to see everyone in person in July in Aguascalientes, and at some of the other meetings as well. I've prepared some formal remarks, and then I hope to have lots of time for Q&A as well, so that we can answer questions that are specific to your practice. I will be giving a view from the United States, where I practice and where I do our research. As you can tell from the title slide, I have very recently moved from my appointment at Johns Hopkins to New York University, although I still remain affiliated with the research group that I started at Johns Hopkins as well. So I'm going to talk about expanded criteria kidney donors, what we used to call ECD. We have different names for them now, but still at the end of the day, these are organs that are less good than the organs we would like to use. And then the question is, when should we be using them, and in whom, and what is the role that they serve? I'll start by just giving you an overview of the landscape of kidney transplantation in the United States. So this is the setting in which I practice. As you can see, we have many more people on the waiting list, new waitlist registrations, compared to people that we can transplant. So every year we list about 40,000 new people, yet we can only do about 20,000 transplants. About 1/3 of the transplants are from living donors, and about 2/3 of the transplants are from deceased donors. So we don't have enough organs, and we're always looking for ways to expand the organs that we were able to use. This is particularly important because if we don't transplant people, they will die, and that is the unfortunate but important reality of our field. So you're looking here at new people in the United States who get listed for a kidney transplant. And after 1, 2, 3, 4 years, what happens to them? And you see that some of them achieve a live donor transplant. Some more of them are able to achieve a deceased donor transplant, and many others die on the waiting list. If you don't get transplanted, ultimately you will die on the waiting list. So in an effort to make this better, we consider expanded criteria, what we call high KDPI, marginal kidneys. We consider kidneys that are not great, but might benefit our patients. Why do we worry about, why are we talking about this tonight? Well, there are high discard rates of these kidneys, more in some places in the world than others. Getting good organs is harder these days. So it's harder to find a perfect organ for somebody on your waiting list. And instead of letting them die, you want to see if you can help them with less good of an organ. We are also transplanting more older adults. So the proportion of our waiting list that is 65 and older is growing every year, and the number of transplants we do in older people is growing every year. And what that means is there may be a good population who would benefit from kidneys from expanded criteria and older donors. When we think about will we accept a high KDPI kidney, we always think it's very easy to think about what happens if you use these organs, but it's even more important to think about what will happen to your patient if you decline these organs. And I'm going to show you data about that. And I'm going to talk to you about efforts that we've been making recently to improve clinical decision-making tools, so to help patients and their providers to make the right decisions about whether this organ is good or not for them. Last year, the United States was embarrassed by a report from my good friend Alexander Lupi in France, where they looked at utilization of marginal organs in France versus the United States. What they did was they took organs on the spectrum of organ quality and said, what is the probability that those would be declined and discarded, so thrown away, in the United States versus in France? And it turns out that for organs where there would be maybe a 30% chance of discard in France, there's an 80% chance of discard in the United States. So we are throwing away many, many kidneys, thousands of kidneys that we could use in the US, that if they had them in France, they would also be using them. And so the French experience made us more aware of how much more we could utilize these organs in the US. And I'm hoping that the US experience will help you figure out how best you can utilize these in Mexico as well. When we talk about these marginal organs, it's important to remember what happened about 20 years ago in our field. So 20 years ago, we had a definition for expanded criteria donor kidneys, or ECD kidneys. These were kidneys that were from older donors with higher creatinine. There was a definition that we don't use today, but an important definition. And Bob Marion at the University of Michigan wrote a very important paper published in JAMA, the top medical journal, looking at the survival benefit of accepting an ECD versus waiting for a non-ECD kidney. And he presented an algorithm where he said, okay, if you follow this algorithm, then you will choose the people who will benefit from ECD kidneys. And it was based on age and diabetes and the waiting time in your area. And so what I call ECD benefit are people who, if you gave them an ECD kidney, Bob Marion's algorithm would predict that they would survive longer if they got transplanted with this ECD compared to waiting for a non-ECD kidney. So 5 years later, we looked at this and we saw that only 50% of ECD benefit candidates were listed to even consider. I don't even mean accept, but I mean even consider an ECD in the United States. And there was huge variation by center. Some centers listed all of their ECD benefit candidates. Some centers listed no ECD benefit candidates. You see here the distribution, and I'm also showing you the distribution based on waiting time, and it was not correlated to waiting time. So people were not making smart decisions about these organs. And the paper that Bob Marion wrote in 2005, when we looked at practice before 2005 and after 2005, we saw no difference. So there was a problem here with our perspective on ECD organs. However, when we looked at this system that Bob Marion wrote actually worked. So if you were an ECD benefit patient, if Bob Marion's algorithm said you would benefit from an ECD and you were willing to accept an ECD, 22% got transplanted versus 14% who got transplanted who were not willing to accept an ECD. So transplant rates were much higher. And even among those who would not benefit from ECDs, 34% of those willing to consider them got transplanted versus only 27% of those not willing to consider them. So that's transplant rate. And then when we look at the actual benefit, those who were expected to benefit from ECDs and got listed from an ECD had a 12% lower risk of death. And those who were not expected to benefit from an ECD but got listed for an ECD had 11% higher risk of death. So it shows us that ECDs are valuable, but they need to be used appropriately. Now, today we don't use ECD because it was a relatively coarse evaluation of a kidney. We have a much more granular evaluation of a kidney today, and that's called the Kidney Donor Profile Index, or the KDPI. So this considers donor age, height, weight, race, ethnicity, history of hypertension, history of diabetes, the cause of death, the serum creatinine of the donor, the Hep C status, and whether it's a DCD, donation after cardiac death donor, or a DBD, donation after brain death donor. The KDPI ranges from 0 to 100%, so 0 is the best KDPI, and 100% is the worst KDPI. And we interpret a KDPI as, if the KDPI is 20%, it means that this organ is worse than 20% of the organs from last year, is higher risk than 20% of the organs from last year. So it's the 20th percentile, which is actually very good. If you're 92nd percentile KDPI, if your KDPI is 92, it means that you're higher risk than 92% of the transplants that we did last year. But remember, we did all of those transplants, so it doesn't mean that this is a bad organ. It just means it's higher risk than some of the other organs. And you see here that 1 year and 2 year survival do correlate with the KDPI, but at the end of the day, even in the worst KDPI organs that we transplant, there is still more than 70% 2-year survival for these organs. So these organs can really bring people substantial survival after transplantation. And if we can put them in the right person, 75% survival might not be that bad. However, our discard rates are very disproportionate to the impact of KDPI on the outcomes. So an organ that has a 2-year 90% survival, we have only 2% discard. An organ that has a 2-year 80% survival, we have 40% discard. So they are not comparable. We discard at much higher rates, even organs that are still quite good to transplant into patients. We've used some mathematical modeling, this is work by my colleague Alan Massey, to try to better quantify what does it really mean to be a relatively bad kidney versus a relatively good kidney? What does it mean to accept a kidney versus waiting for the next best available kidney, etc. And so what I'm going to show you are data from a study where we said, do you accept a kidney with a KDPI in the 70s, or do you wait for a kidney with a KDPI less than 70? Do you accept a kidney from a KDPI in the 80s, or do you wait for a kidney with a KDPI less than 80? Do you accept a kidney from a KDPI in the 90s, or do you wait for a kidney that with a KDPI less than 90? Do you wait for a better available kidney? Interestingly, no matter what category you do this for, on average, among all of the people who have been transplanted compared to those who stayed on the waiting list, taking one of these organs is better than waiting for a better organ. So you have better survival no matter what the KDPI is for that organ if we transplant that organ today versus waiting for the next best available organ. And how does this translate into what happens to people? So this is a graph looking at people who were offered their first KDPI kidney with a KDPI of 80 to 100%, and they said no. What happened to them? By 5 years after saying no, even if they had other offers, by 5 years after saying no, 42% of them died on the waiting list. 45% of them got transplanted somehow, some with a living donor, some with a low KDPI organ, and some finally just gave up and took a high KDPI organ, and 13% were still waiting at 5 years. How does this compare to those who accepted the organ? So again, this 18.7%, these are people who were offered an organ with a KDPI of 80 to 95%, and this is their mortality if they accepted that kidney, and this is their mortality if they declined that kidney, no matter what else happened to them. And you see that if they declined it by 5 years, their mortality was 27%, and if they accepted it by 5 years, their mortality was only 18%. Even those kidneys with a KDPI of 96 to 100, there is a better survival in those who accept it versus those who decline it. Or should I say, there is higher mortality in those who decline these organs than those who accepted them, even if the ones who declined it ultimately had the opportunity to get transplanted. Now, one thing that's important to remember is this is on average. This is across all of the people who are offered these organs and whether they accept the organ or decline the organ. But as we know, we take care of patients as doctors or coordinators, and we know that some patients might have a good advantage from taking this, and some patients might not be the right people to accept these organs. In this paper that we published, we tried to better characterize who would benefit from a high KDPI organ, who would have equipoise, and by equipoise I mean some there's some chance they'll benefit, there's some chance they'll be harmed. It's probably equal. And then who would be harmed by this? So for example, let's look at organs with a KDPI in the 90s. If you're over 50 and you're at a place where your waiting time is generally longer than 33 months, you will benefit by accepting this organ. If you are under 50, you're at a center with shorter waiting time, and you're not diabetic, you're going to be fine on the waiting list, and you probably will be harmed by accepting this organ, so you should wait for something better. And if you're in the middle, that's where our clinical judgment comes in. That's where we have to say, well, this person, I think they'll benefit, or I think they'll be harmed by this higher risk organ. When we stratify this survival benefit by these different categories, we can see that in some instances, some categories have tremendous benefit from accepting these organs, and some just don't. So if you're looking at a KDPI 90 to 100, and you're over 50 with long waiting times and you're diabetic, you will have a 14% reduced mortality if you take this versus waiting for the next best available organ. However, if you're under 50, you have short waiting time and you're not diabetic, then you're going to have a 68% higher risk if you take this organ versus not taking this organ. The KDPI in the 90s are what we might call the most marginal organs. Those in the 80s are what we might call the typical marginal organ. And you see, for organs in the 80s, no matter what category you're in, there is never harm in taking one of those organs. And in some categories, there is substantial benefit in taking these organs. So this gives you a little bit more of a patient-centered view based on patient age, the waiting time, and whether they're not diabetic. We can get even more granular with the patient-centric view by looking at work from my colleague Sanjay Bay, who is an expert in machine learning techniques and who tried to find the right match between the donor and the recipient. And if you go to this website, you can look at this calculator. You can enter the EPTS score for the patient. So in the US, that is the estimated post-transplant survival score. And you can enter the KDPI of the donor, and it will tell you how much survival benefit the patient will get. And by survival benefit, we mean the survival with the transplant versus the survival without the transplant, waiting for the next best available kidney. So here in this demonstration, you see that this person with these characteristics, if they remain on the waiting list, they'll have a 62% survival. If they receive this kidney, they'll have an 84% survival by 5 years, and we expect that the survival benefit will be an additional 22% survival at 5 years. We can get a lot more granular data about this. So if we find the EPTS score here, then what we can do is, based on the EPTS score and the KDPI of the donor, we can see what line they're in. And based on what line they're in, what color they have, we can then estimate the survival on the waiting list, and we can estimate the survival after getting transplanted. And then when we subtract the two, we get this map where we enter information about the donor and the recipient, and it will tell us the darker the green, the more survival benefit there is for this patient. So the patients with the highest risk patients who get any organ offer whatsoever will benefit from that organ offer versus waiting for a better organ, whereas the very low risk patients will benefit to some extent from all organs, but will benefit the most from non-marginal organs. So this gives us the opportunity to start really thinking about, well, we don't want to throw away these organs. That seems wasteful, but there might be people who are better suited for these organs versus people who are less well suited for these organs. One thing that we've understood in the last couple of years is that aggressiveness of transplant programs has patterns associated with it, and these patterns relate to institutional experience and comfort with certain organs. And what you're looking at here is different types of marginal organs. So older donors, older DCD donors, donors with high terminal creatinine, donors who are Hep B core positive, donors who are hepatitis C positive, donors with long cold ischemia time, and organs imported from other geographic areas. And if the bar is dark orange, then that center had a lot of utilization of those organs. And if the bar is very light, then that center had very little utilization of those organs. And that's important to look. For example, here is a center that is completely comfortable with older DCDs, but not at all comfortable with kidneys that had acute kidney injury, probably because there's somebody there who, when they trained or the last place they worked, they used DCDs and everything was fine, but they've never used organs from high terminal creatinine. They don't know who to put those into. They don't know how to manage them. And as a result, they're not aggressive in the use of those organs. And what we hope that this shows the community is that if we teach each other and we improve education about these organs, then things will get better and people will feel more comfortable using other types of marginal organs, not just the types that perhaps they've used in the past. DCD organs are a great example. Utilization of DCD organs in some parts of the world is very, very poor. Utilization of DCD organs in the United States is actually quite good. And we even use organs from DCDs over the age of 50. And if you look here, in the last 10 years, we've started using them more and more and more. Why would we use organs from DCDs over 50? Well, again, if we don't use them, then the person on the waiting list has a chance of dying. And for example, of people offered a kidney from an older DCD over the age of 50 who said no, no matter what they did later, by 5 years, 45% of them are dead. Only 50% of them got transplanted and 6% are still waiting. And of those who got transplanted, about 10% either got a living donor or a better organ, while some of them finally gave up and decided, okay, I'm going to accept an older DCD. Similar to the graph I showed you before, those accepting DCDs have half the mortality of those declining DCDs. So if no matter what else happens to you, if today you accept a DCD, we expect you to have a 5-year mortality of about 23%. Whereas if you decline a DCD over the age of 50, we expect your 5-year mortality to be 34%. We have similar findings when we look at people who were offered kidneys from donors who had acute kidney injury, or AKI donors. These are donors with high terminal creatinine who we don't think had intrinsic pathology of the kidney, but who we think had an elevation in their terminal creatinine because of brain death injury causing some sort of ischemia to the kidney, or other physiology causing temporary ischemia to the kidney that we expect will resolve, and in the studies of AKI kidneys has definitely resolved. Those who turn down AKI kidneys, again, these are people who had one AKI kidney offer and said no and are waiting for a non-AKI donor. About 50% of them were dead by 8 years. About 40% of them got transplanted, some with a living donor, some with a kidney that did not have AKI, but interesting, many of them were from donors who did have AKI, and the patients just finally decided, I don't want to keep waiting. I will accept the next AKI kidney that I'm getting. And then a very small handful were still waiting as well. Again, when we look at the survival of those who've accepted AKI kidneys versus those who declined them, we see that if you accepted an AKI kidney, by 7 years post-transplant, you have a 15% mortality, where if you declined it and you waited for the next best available kidney that was not AKI, you had a 30% chance of mortality. So accepting the kidney while you had an opportunity doubled people's survival benefit. Interestingly, those who declined an AKI kidney and later accepted a non-AKI kidney, declined a kidney that had a median KDPI of 37, and later accepted a kidney that had a median KDPI of 50. So a huge difference in quality of the organ when judging non-AKI and AKI kidneys, meaning that those who said, I don't want a kidney with an AKI, turned down better organs by KDPI than those who than those that that they ultimately ended up accepting. So I've showed you data from the United States that motivates our discussion of expanded criteria, high KDPI, marginal kidneys. We worry about these kidneys because they have high discard rates. We don't use them effectively. We don't even pursue donors at OPOs where there's a worry that we have these high KDPI kidneys. We are much better about this now than we were 10 years ago in the United States. And we're better at it because the organs that are the best organs are harder to find because more and more people are waitlisted. And we are transplanting more and more people, particularly those over 65, those over 50. We're transplanting more and more people who are older and would benefit from these organs. And when I say benefiting from these organs, I mean, if you think about what happens if you use these organs only, then you say, well, the outcomes are worse than standard kidneys. Of course. But the real comparison is not what happens between a high KDPI versus a low KDPI transplant, because your patient is not being offered a low KDPI organ right now. They're being offered a high KDPI organ. The question is, what happens with this patient if they accept this high KDPI kidney versus if they wait on the waiting list with the chance of death, with the chance of cardiovascular events, with the chance of other accumulated mortalities, for them to get a better organ offer? Is it worthwhile for them to wait 5 years to get a better organ offer? Probably not. And it's important to quantify who would benefit from this and who would not. And I've also showed you some clinical decision-making tools, starting very coarse and getting more and more granular with the information we can put in for the patient and for their donor, and to see who would benefit from accepting what marginal organs. And I showed you that there are some centers who, without the right expertise and data and guidance, do not even feel comfortable going anywhere near these organs, where there are some centers that use them for almost 100% of their patients. I can tell you, I just came from a very aggressive center, and I'm here now at an even more aggressive center. And when marginal organs are offered, we find the right people to transplant them into so that these organs will not be discarded. I'd like to thank you for your time. I'm showing you this photo from Monterey that I took in 2018, which was the last opportunity that I had to visit Mexico in person. I'm very much looking forward to visiting Aguascalientes and also to seeing everyone in person. And I did see in the chat that some people are from Monterey, so hopefully you enjoy this view of the beautiful mountains in your countryside. So thank you again for the opportunity to present, and we've left lots of time for discussion and Q&A, and I'm very interested to hear what the landscape is like in Mexico and what the concerns are and what we might be able to do with clinical experience, but also with data to help guide these decisions.
Muchas gracias, doctor Segev, por esa presentación tan padre. Tenemos saludos de Lima, Perú, varios saludos de Monterrey, tanto del Seguro Social como de otras instituciones, saludos de Guadalajara, saludos del ISSSTE, y en Monterrey dicen que son sus fans, doctor Segev. Así que vamos a abrir la oportunidad de hacer preguntas, tanto en la plataforma de Facebook como a través del chat o a través de las preguntas y respuestas. La primera pregunta que tenemos acá es de Enrique Hernández. Él lo felicita por una excelente discusión y le pregunta acerca de la utilización de estos órganos para receptores pediátricos.
Yeah, this is a very good question. You know, when we transplant somebody who's 62 years old, we generally don't expect that they will need a second transplant. When we transplant somebody who's 12 years old, we do expect that they will need a second transplant. And so we worry a lot about sensitization, and we worry about the longevity of the organs. As those of you who transplant pediatric patients know, the highest risk to that organ is not the quality of the organ, but is the medication adherence of the recipient. We know that about half of pediatric patients lose their transplants between the ages of 17 and 24 when they transition into adulthood, when they become 18-year-olds. We know what 18-year-olds are like in their whole life. We also know how they are with their medication adherence. So there is a balance. We don't want them to be sensitized. We want them to have the longest life possible from their allograft, and we have to think about all of these issues. I think in general, where I work in the United States, we have prioritization for pediatric patients, which means the best organs are prioritized for pediatric recipients. As a result, we generally don't think about high KDPI organs for pediatric recipients. We think about these more for adult and maybe even older recipients. The exception for this is the sensitized pediatric recipient who might find a zero mismatch or a immunologically perfectly matched organ that might be a little bit older with a slightly higher KDPI. In those instances, that might be an absolutely reasonable choice for that patient. But in general, on average, when I think high KDPI organ, I'm thinking one of the older patients that I transplant.
Muy bien, doctor Segev, gracias por la respuesta. Tenemos dos preguntas similares, entonces vamos a tratar de separarlas. El doctor Covarrubias y el doctor Escareño están preguntando algo acerca de la bomba, y hay otras, Lorena Noriega y también César están preguntando acerca de biopsia. Vamos a tratar de separarlas. La primera pregunta, doctor Segev, es si la utilización de los riñones con KDPI alto es condicionado al utilizar una bomba de perfusión, ya sea normotérmica o hipotérmica en su centro.
Yeah, that's a very good question. And pump is one of those still unanswered questions in our field. I will tell you that when I started practice in 2006, we pumped every kidney, always. Then we did this in the context of a trial, and we realized that the pump was not helping at all. And so we actually stopped pumping organs, and the only time now that we would use pumped organs is if somebody already put it on the pump. But we would not, by our own decision, put an organ on the pump. I think one of the, so we have to, there are two reasons to put something on the pump. One is because you think it will actually improve the organ, like these dramatic results we see for steatotic livers, or dramatic results we see for lungs that they can't even breathe, and then you put them on the pump and then they expand really beautifully. And there's more data coming out for heart as well for improving the organ itself. But for kidney, there's the question of whether it improves the organ, and then there's the question of whether it improves your clinical decision making. So if you think that you're going to get useful information from the pump that would help you decide, is this a good organ versus is this a not a good organ, then maybe then you would gravitate to using a pump. I think for the most part in kidney, the overwhelming philosophy is that pump is much more helpful in terms of giving you information about whether an organ is useful, and not as helpful about actually improving the outcome of a transplant. And I think if you combine clinical information with biopsy information, you have all that you need, and it's very rare that I really want the pump numbers. And in fact, sometimes I hear pump numbers that are terrible and everything else looks fine, and I transplant it and it works immediately. So I think we can get misled by these pump numbers as well. I do not consider pump to be essential for the decision about whether to use a marginal organ or for the improvement of the organ itself. Now, biopsy is a different story. There's still, if you ask 50 transplant surgeons about whether they use a biopsy, 25 will fight you that a biopsy is essential, and 25 will fight you that you are wasting your time with the biopsy. And I think that, and this is quite similar to pump, I think it depends on the quality of the person reading the biopsy. So just like pump numbers are useful if you know the pump, you know the technician, you have 20 years of experience with this pump, maybe you'll get some useful information out of it. But if it's a random pump that was used at a random hospital, you're not going to learn anything from it. Same with the biopsy. If the people writing the Banff criteria are available at 3:30 in the morning and are reading your biopsies that was done, with a large core biopsy and deep into where you can see the vessels and things like that, then a biopsy is amazing. If a first-year medical student at 3:30 in the morning who doesn't even know how to obtain a biopsy, let alone read one, is the person you're relying on for biopsy information, then a biopsy is not very useful. Where I have practiced, we've had experts who are available in the middle of the night. And actually, as a surgeon, I was trained also as a pathologist to read the biopsies myself. And I was told, if you don't look at the biopsy yourself, you can be misled by the pathologists. And so we became very good at reading the biopsies. And with my read and the read of one of the pathology experts, I found that the information was useful. There is, for example, the MAPI score, the Maryland Aggregate Pathology Index that my colleague Ben Filosof developed when he was at the University of Maryland, validated in multiple populations, identified ways that you could standardize biopsy reading. And I think if you can standardize your biopsy reading and you have people who are experienced with reading biopsies, biopsies are very useful in this. If not, then again, it's just like the pump. It's better to just look at the clinical characteristics than it is to worry yourself about the biopsy. I mean, if the kidney was working perfectly fine with a creatinine of 1.0 in a 50-year-old who didn't have a lot of medical problems, I don't care what the biopsy looks like. That biopsy will be wrong because that kidney works perfectly fine in that donor. Similarly, if the kidney was a complete disaster in that donor and that donor was 2 months from being put on the kidney waiting list themselves, I don't care if a pathologist tells me that the kidney looks perfect. That just doesn't make sense. So I think you need to think about who's doing the reading and how close are you to the line of accept or decline for your patient. If by clinical characteristics you're very comfortable with it, then there's very little that a biopsy can do to dissuade me from using them.
Excelente respuesta, doctor Segev. Le mandan saludos tanto a usted como a nuestra mesa directiva desde Colima, Guanajuato, y desde la Atenas veracruzana, desde Jalapa, Veracruz. También hay una pregunta bastante interesante acá en el chat, que es acerca de los pacientes altamente sensibilizados. Yo creo que en esa población es particularmente importante la oportunidad de trasplante, y lo que le preguntan es qué hay acerca de utilizar o aprovechar esta oportunidad para pacientes altamente sensibilizados, con riñones con KDPI alto.
Yeah, that's a very, very important point. Some of this, just like our discussion of pediatrics, some of this is based on our allocation system in the US. As you know, if you are PRA 100% in the United States, you have the highest priority for any kidney that becomes available, so you can be selective. In fact, transplant rates for patients who have PRA 99%, 100% are quite good. However, slightly below that, the worst PRA to have in the United States is 96%, because there's no benefit and you are at the highest risk of not finding yourself ever a donor, because the PRA 100, 99%, they're stealing your organs that are hard to find. And then you are sensitized and no, you're not going to find any other organs. So I think for the highly, but not super, super, super highly sensitized patients, these are ideal organs. And you really cannot be selective based on KDPI. If the KDPI is 90, it may be the only organ offer this person sees in 7 years. They're going to die without the transplant. I think, accept the organ, particularly if it's somebody who's not young, is not prioritized by the allocation system. So I think when we, KDPI only considers the donor itself, and it doesn't consider the recipient factors and this donor-recipient interaction. And I think donor-recipient matching is a really important concept that we have not included into the KDPI.
Muchas gracias. También nos mandan saludos desde Puebla, la doctora Barrientos. Le quiero dar la oportunidad tanto a la doctora Medeiros como al doctor Morales si quieren hacerle alguna pregunta al doctor Segev.
Adelante, Luis Eduardo.
Hola, doctor Dorry, ¿cómo está? Muchas gracias por esta excelente ponencia. Un punto importante es en qué momento informar a los pacientes de esta posibilidad de inscribirlos para aceptar un órgano marginal o con un KDPI alto. ¿Es al momento de enlistarlo o en cualquier momento se puede anotar, digamos, como potencial receptor de este tipo de órganos? Y si se llena un consentimiento informado especial para esos casos.
Yeah, this is really important as well, because there are two sort of big times that we interact with the patients, right? One is when we meet them. We know they're not going to get transplanted for several years, depending on what waiting list they're on. And we give them probably an entire PhD worth of education in 6 hours. And that's when we say, oh, you might get high terminal creatinine, you might get high KDPI, you might get infectious risk donor, you might get DCD, you might get older DCD, you might get Hep C organ, you might get Hep B core organ, and we give them all this information and they cannot process it. I mean, we can barely process it. We are having debates here, you know, among the world experts about what to do with these organs. Obviously, our patients cannot process this. So we give them the information up front. And what we do is we see people for reevaluation. So let's say somebody needs to have a new stress test or needs to get other new evaluations. They need to keep their colonoscopy up to date, etc. When we see them again, and now it's getting closer to when they might get an organ offer, we remind them of those conversations that we had with them. And then obviously the day they get the offer, we also give them that conversation. We show them the curves. We say people who say no to this organ, this is their mortality. People who say yes to this organ, this is their expected mortality. We show that we give them numbers. We show them the curves. We help educate them. We say, I'm giving you an organ offer. You might not see another offer for another year. Really think about that and how you're doing on dialysis and what the impact might be for you. But I think that these conversations need to happen often and as clearly as possible with the patient. I'll give you an interesting example. So a few years ago, we created what we called the Living Donor Champion Program. This was to help people find living donors among their social networks, okay? This had nothing to do with deceased donors, but in the process of helping people find living donors, we helped teach them what is the outcome of a living donor, what is the outcome of a deceased donor, what is the outcome of a high KDPI, what is the outcome of each of these different things. And we had people on our list who had declined 5 or 10 marginal organs. And the day after they came to our Live Donor Champion educational program, they got another marginal organ offer and they accepted it. So they participated in a program trying to find a living donor, but because they got re-educated, now that they had been on the waiting list thinking about things, they couldn't remember anything from the initial education session, but now they said, oh, wait, I'm being really crazy to turn down these organs. They just told me these organs are pretty good organs, and then they would accept that. So that was a very stark reminder to me that the more we educate people, the more we really tell them the reality, the more likely they are to be excited about organs that aren't the top organs. When I was junior faculty and I saw many patients in evaluation clinic, my reputation was that I made all of the patients cry in evaluation clinic. And it was because I showed them what their mortality would look like on dialysis. And nobody ever told them that. Their nephrologist never told them in 5 years, you have a 50% chance of being dead. And I said, look, you need to know this because when you're thinking about, do I accept the very best kidney, the next best kidney, etc., you need to know that in 5 years, you have a 50% chance of being dead on dialysis, and that should impact the decision that you make. And I think that it's something we don't remind our patients a lot of. We compare the best organs with the next best organs, but we never compare the kind of marginal organ with waiting on dialysis.
Muchas gracias, doctor Segev. Excelente presentación. Yo soy nefróloga pediatra y coincido con usted de que el primer trasplante debe ser el mejor en un paciente pediátrico porque debe de ayudarlo a llegar a la edad adulta donde probablemente requiera un segundo trasplante. Mi pregunta es en relación a si hacen alguna maniobra para mejorar la calidad de esos riñones que ya tienen criterios extendidos, como el uso de bloqueo de mineralocorticoide o algún tipo de medicamento que pudiera mejorar la función de estos injertos.
Yeah, that's a good question. Sadly, I don't think there's much in terms of pharmacological interventions that have been shown to improve transplant outcomes in people who receive sort of marginal organs. There is some management that is very important. So, for example, if you know that this organ is marginal and one of the risks associated with this organ is a higher risk of delayed graft function, then maybe two things would happen. One, if the patient had low ejection fraction, poor cardiac function, blood pressure, lability on dialysis, you might not choose that patient for an organ that you know has a high risk of delayed graft function. If you think that they can tolerate it, but you still know that there will be delayed graft function, you might be much more careful for example, in the initial initiation of calcineurin inhibitors that can be nephrotoxic. And you might target either very low levels of CNI or maybe without CNI, but with thymoglobulin induction so that you have a window during the early parts of the transplant where there's endothelial injury and you don't want the CNI to add more injury to the exposed endothelium during the period of delayed graft function. And so you might choose early management strategies to mitigate the potential harm of the delayed graft function, for example. In the long run, I'm not aware of pharmacologic interventions that would impact a marginal kidney differently from a good kidney, but I also, for full transparency, I do not take care of pediatric recipients, and so there may be things happening on the pediatric side that I'm not aware of.
Muchas gracias.
Ok, muchas gracias. El doctor Covarrubias le agradece por sus aportaciones. Yo tengo una pregunta y me gustaría platicarles del correo que le envié, doctor, para invitarlo a dar esta plática. Mi pregunta es acerca de la aplicabilidad del KDPI afuera de Estados Unidos. ¿Hay alguna validación para su uso en otros países? Porque la herramienta está utilizada para comparar el riñón potencial contra los resultados de los años anteriores en Estados Unidos. Entonces, ¿hay experiencia con su aplicación fuera del país?
So other countries have looked at validation of KDPI. And remember, KDPI is derived from KDRI, right? Kidney Donor Risk Index is like a number between 1 and 7, and then they take it and they map it to 0 to 100% based on the transplants that occur in the United States. So you can, if you want, you don't need to use KDPI, and you can use KDRI, and maybe you can map KDRI onto like the Mexican Transplant Registry to see what percent does this mean in your country or something like that. I would say that regardless of what the practice is in Mexico or whatever country we use, a KDPI of 90 is going to be worse than a KDPI of 60, right? So it'll give you a relative comparison, but in terms of comparing to the entire population of transplants that you use, it might not be good. That said, because the utilization of marginal organs from deceased donors in Mexico, from my understanding, is quite poor, I don't think you want to compare a given organ to the practice patterns in Mexico. I would say maybe compare that to the practice patterns in the US and say, well, in the US, these would be easily used, so maybe we should think about using them in Mexico as well. In the same way that right now, I'm looking at organs saying, well, in France, they would use this organ without even question. Why are we even thinking about discarding this organ, in the hopes that we will grow to be as aggressive as they are in France? And then, you know, the hope would be that others would follow that same lead.
Muchas gracias. Les voy a leer un pedacito del correo que le mandé al doctor Segev. Espero que con eso podamos cerrar, si no hay alguna otra pregunta del panel o de los miembros. Lo que le comento al doctor es que en México el trasplante renal de donante vivo representa el 71% de los trasplantes que se hacen y que no hacemos trasplante de donador en parada circulatoria, y que nuestra tasa de donación en muerte encefálica es baja, es de 3.85 donantes por muerte encefálica por millón de habitantes. Durante la última década, del 2012 al 2021, se recuperaron 4.529 donadores por muerte encefálica y solamente se descartaron 411 riñones. Al analizar este número de forma aislada, podríamos llegar a la conclusión errónea de que la utilización de donantes cadavéricos en México es muy alta, igual o más alta que la de Estados Unidos comparada con los números. Pero lo que vemos en nuestra práctica diaria es que muchos de los donantes que tendrían esta denominación de criterios extendidos o KDPI alto, en realidad no son recuperados, y que eso hace que el denominador se reduzca y que la utilización parece que sea más alta. Entonces, la invitación a todos los coordinadores de donación que nos ven y a todos los nefrólogos y cirujanos de trasplantes es que por favor se les dé la oportunidad de considerar estos donantes para los pacientes que reúnen las características que el doctor Segev nos ha platicado el día de hoy. No sé si la doctora Medeiros o el doctor Morales quisieran hacer un comentario final.
Yo creo que, gracias Daniel, creo que es importante aumentar nuestro conocimiento acerca de los órganos que podemos utilizar. Ya en el mundo no solamente se utilizan donadores marginales, ya comentaban los donadores con falla renal aguda, aquellos con hepatitis C, en otros lugares HIV para HIV, es decir, la gama de donadores que antes se rechazaban, se está reconsiderando muchos de ellos para aumentar el pool de donadores, y creo que es importante que todos los coordinadores de trasplante, que son el primer contacto de los potenciales donadores, pues estén al día en estos puntos, ¿no? Y pues creo que la educación médica continua pues es parte de las herramientas para ir avanzando en materia de trasplantes. Muchas gracias, doctor Dorry Segev.
Muchas gracias. Excelente presentación, excelente coordinación y un gusto verlos. Espero también ver al doctor Segev en Aguascalientes.
Muchísimas gracias a todos, gracias doctor Segev, y gracias a todos a los que nos acompañaron. Tuvimos a más de 100 participantes en vivo y esperamos que en la retransmisión de esta plática pues pueda beneficiarse más gente de los conocimientos del doctor Segev y de la interacción con este panel. Muchísimas gracias, Dorry.
Thank you. Great to see everyone.
Buenas noches.
Thank you so much, Dorry. I'll email you in a little bit.
Great. Awesome. Yeah. Thank you. Great to see you.
See you. Bye.
Bye.